Okay, so let's start with some information about the clinical burden and how we can manage cytopenia in myelofibrosis. On these slides, you see some drivers of anemia in myelofibrosis, just to highlight that indeed this is a multifactorial problem, maybe not fully understood. On the left, you can see some kind of mechanical issues like splenomegaly that induces red cell sequestration, the tissue fibrosis in the bone marrow, the inadequate erythropoiesis in extramedullary sites, and on the right part, the changes induced by pro-inflammatory changes that were discussed in several talks during this meeting, some genetic risks factors such as U2AF1 mutation, for example, the hepcidin pathway, we heard about that, that is very important, and obviously also JAK inhibitor therapy that worsens anemia for some of the drugs. The same cartoon for thrombocytopenia. I will not go into the details, but also the same almost issues with still the JAK inhibitor therapy that even worsen thrombocytopenia in some of these patients. Those we have to take this into account. What is the incidence of cytopenia in myelofibrosis? Indeed, anemia is present in about 35 to 38% of the patients at diagnosis, and this incidence increases over time, reaching 58-64% for the patients after 1 or more than 1 year of follow-up. The same for thrombocytopenia, present in 18% of the patients and increasing over time, 28-31%. So this is really an important issue for these patients. In addition, anemia, when leads to transfusion dependency, it's the case in 24% of patients anemic at diagnosis, but you can see that almost half of the patients will become transfusion dependent during the course of their disease, and transfusion dependence is associated with poor outcomes, such as a major risk factor for iron overload, of course, inversely correlated with the quality of life, poor survival, we will see that at the end of this talk, and a substantial burden in patients. And indeed, when you ask patients, 80% of patients report that reducing transfusion frequency is an important treatment goal for them. In addition, anemia and thrombocytopenia are correlated with a series of symptoms, and it has been shown, for example, that thrombocytopenia is associated with all this list of symptoms, especially in severe thrombocytopenia. And anemia obviously is associated with fatigue, impaired physical functioning. And this symptom burden is important, and they are both, anemia and thrombocytopenia, associated with an increased total symptom score when you assess that with the TSS tool. In addition, of course, these cytopenias have important impact on the quality of life, and most patients with MF report a reduced quality of life due to these symptoms. And improvement in this quality of life is a treatment priority, obviously, for a lot of patients with myelofibrosis, and not only other endpoints, as we say, such as survival. Anemia is consistently correlated with adverse quality of life and a key treatment goal in these patients. And in addition, reduced quality of life is experienced more often by patients with thrombocytopenic MF than those without thrombocytopenia. Finally, cytopenias also do lead to change in our treatment strategy or the way we treat these patients, and treatment modifications due to cytopenia in patients are summarized on these slides. It leads often to dose reduction in more than 60% of the patients, interruption in almost more than 1/4 of the patients. Rarely, due to the discontinuation of the drug, is due to anemia or thrombocytopenia, because either we propose transfusion, or we are not afraid sometimes to go very low in the platelet count of our patients. But still, we may lose the efficacy of our treatments if we have this too much dose reduction need or dose interruptions during the course of their disease. And you can see on these slides the impact of cytopenia on major outcomes like median overall survival by anemia, and you see that the presence of severe anemia or transfusion dependence in MF is associated with a 1.4-fold increase in the risk of death compared to moderate or mild anemia. And the presence of thrombocytopenia is associated similarly with a 1.4-fold increase in the risk of death compared to patients with platelet counts above 100,000. So not only the presence, but also the severity of this cytopenia, anemia, and thrombocytopenia is associated with progressively poorer overall survival in patients with MF. So altogether, cytopenia management is really important to patient-centered care in MF. We aim to reduce the transfusion dependence. You saw all the poor outcomes that were related to this transfusion dependence, to improve the quality of life of our patients, to reduce the requirement of dose reduction or interruption, and ultimately, of course, to improve the prognosis of these patients with cytopenic myelofibrosis.